event, Feast for Innovation, Models for Implementation, Family Health Weight Programs, and Health Centers. My name is Elizabeth Breidenbach. On behalf of MAC, thank you so much for joining us. While we get started, I would like to review a few housekeeping announcements. First things first, you are being recorded right now. This Zoom meeting or this Zoom webinar is being recorded. Automatically joining our meeting automatically consents you to this recording. If for some odd reason you do not feel comfortable being on this live recording, please exit. But again, you'll be able to play this information on playback at a later date. So again, this event is being recorded today. Audio connections, you either use physically called in or use computer audio. Each option is completely fine. I always recommend, though, that if you're in an area where Wi-Fi can sometimes be a little bit spotty, physically calling in is typically the best manner. This way you don't miss any of the live content. Audio and video, we are in Zoom webinars, so those features should be disabled for you. So you cannot open your line, you cannot share video as well, completely normal. This is really just to avoid any sort of background noise interference. So again, audio and video is disabled for all attendees today. Q&A box is open though for you guys, so we'd love to see your question throughout today's segment. We did receive some pre-submitted questions in advance. Thank you so much for that. So again, if you'd like to ask any of our panelists any sort of questions or have comments throughout today's presentation, the Q&A box is open. Located at the bottom of your screen, you may have to take your cursor and toggle that down to open it. If you're in full screen mode for Zoom, you need to minimize that just to kind of get that box open. But once it's open, feel free to type your questions. If you're somebody that likes to hone in on technology, if you see a question into the Q&A that you want to upvote, that means it's a really popular question and you really want our panelists to answer that, feel free to do that as well. We'll try to answer as many questions that we can in the time allotted, and for some odd reason we cannot answer your questions in the time allotted, we'll make an attempt after the event has been completed. Again, friendly reminders, today's event is being recorded. All registered attendees, today you'll receive a copy of today's recording, slides, and any sort of resources that we mentioned, whether that's a link or a physical document within 5 to 10 business days via email. So just a little heads up before the CHI conference that's happening in about 10 days from now, you'll get all that content before we leave for CHI. Again, all attendee lines have been muted and the Q&A box is open. At this time, I'd like to turn things over to Sarah and we'll be going and kicking off today's segment.
Excellent. Thank you so much, Liz. My name is Sarah Price. I'm the Director of Public Health Integration at NAC. And it's been such a delight to work in the past with all the speakers you'll be hearing today. And so what we wanted to do today is bring them together to provide a feast of innovations around pediatric weight implementation, specifically in health centers, but throughout communities as well. So what you'll be hearing today is several speakers going through some foundational information, but also very specific programs that might be of option to you at your health center or in the places you work. So as we begin, we'll be going through, but what we would love for you to do is in the chat, put your name, your organization, and if there's a specific either pediatric or family weight management program you're currently using in your work, or a specific intervention or approach you're using, feel free to put that in the chat for us as well. We'd love to follow up with you and to be able to get to know you better as we go through. So first up, what you'll be hearing from Captain Heidi Blank from the CDC. We have a pre-recorded information from her. So sit back, relax, and we'll hear first from her. Thank you so much.
Hello, everyone. This is Captain Heidi Blank. I serve as Branch Chief of the Obesity Prevention and Control Branch in the Division of Nutrition, Physical Activity, and Obesity. We are located in the Centers for Disease Control and Prevention in the National Center for Chronic Disease Prevention and Health Promotion. Today, I'm going to speak with you about childhood obesity prevention and management, interventions. Hello, everyone. This is Captain Heidi Blank. I serve as Branch Chief of the Obesity Prevention and Control Branch in the Division of Nutrition, Physical Activity, and Obesity. We are located in the Centers for Disease Control and Prevention in the National Center for Chronic Disease Prevention and Health Promotion. Today, I'm going to speak with you about childhood obesity prevention and management, interventions that make a difference, and the role of partners in national action. As we talk about obesity, I wanted to talk a little bit about the biology and pathways. Obesity is a complex multifactorial condition that involves appetite regulation and energy metabolism. Adipose cells, or what we'd call body fat, are metabolically active cells that can create health problems when in excess and depending on where they're located. We know that fat cells release hormones that can create chronic inflammation, and fat cells can deposit in organs, tissues, and muscles and cause conditions such as fatty liver. The science of obesity has evolved over the last 20 to 30 years, and we're continuing to learn more about the biology. We also think about what are the causes and consequences. Many factors can contribute, including the foods we eat, things like the amount of added sugars, overall energy, the quality of the diet, and how that interacts with our microbiome, how much energy we use, and the thermic effect of food. That can include our physical activity, our sedentary behaviors, and also how we deal with stress. It also includes our hygiene around sleep, exposure to chemicals, as well as medications that can have weight side effects. All of these type of behavioral factors can interplay with larger society. So for example, how we go about our days is impacted by the built environment. This is an area we would maybe call commercial determinants of health, social determinants of health. And we also now are learning more about how perceived racism, structural racism, impacts our ability to both have healthy nutrition and physical activity, but also stress. We're learning a lot more about genetics and epigenetics and how this impacts our metabolism, our appetite, and our responses. And also early on, from both in the womb, through breastfeeding and early exposures, our learned preferences, our unconscious conscious bias, and how we deal with things such as scarcity and trauma. All of these factors can play into adiposity. In the past decade, we've also learned about how biology changes after weight gain has happened, how it impacts satiety, and if we try to lose weight, how that impacts our ability to change. We also have learned that for folks who already have weight gain, they have a lower metabolic rate that actually promotes more caloric intake and less energy expenditure. So the body doesn't want to lose those additional pounds. So the misconception is held widely that this is a lifestyle choice or a lack of willpower, but we know that there are strong forces in both biology and systems at play. So focusing on it as an individual problem has led, unfortunately, to weight stigma and a misunderstanding of the metabolic processes, the interventions, and inequities that we have. So in our division of nutrition and physical activity and obesity, we work with clinical partners, with health systems, with community partners to really try to reach as many families and children as we can. And in this work, we would say this is a population-based approach to supporting individuals' nutrition, physical activity, and lifestyle. And with kids, we really think about them having the ability to thrive and have healthy growth and wellness. So we work with partners at multiple levels to establish healthier communities to support individuals, as well as settings within the communities. This shows a continuum across the life course of some of the nutrition interventions that we work on. So for example, supporting breastfeeding through baby-friendly hospitals and early maternal physical activity and nutrition. We think about those first 2 years of life and important brain development through early child nutrition interventions. As children grow and attend childcare or get ready for school, we think about the increasing ability to have nutrition standards and physical activity guidelines as part of early care and education programs, school and youth programs, as well as really supporting local growers and farmers as part of farm to education. We also talk quite a bit about new evidence-based interventions that are spreading and scaling across the US to really support children who already have obesity. We call these the Family Healthy Weight Programs. And then in adults, we talk about community-wide approaches that we can have, such as food service guidelines. These are nutrition standards and behavioral design options that can happen in places that we spend our time. This could be work sites, faith-based organizations, hospitals, park and recreation. How do we create healthy defaults? During the pandemic, we've also pivoted and done quite a bit of work in nutrition standards in the charitable food system. So really ensuring that those most at risk and most at risk for chronic disease don't just have food, but healthy food that's culturally preferred. And then community-wide supports for food and physical activity. And all of this really trying to bring about awareness on our journey here of understanding both health disparities and what can improve health equity. This is a slide just to share a little bit about the burden of childhood obesity. This is from CDC's National Health and Nutrition Examination Survey of what we call NHANES. This shows the past couple of decades on the prevalence of obesity in US youth 2 to 19 years from 99-2000, the first left data point, through what we had pre-pandemic. And that was data that we've compiled of the 2017 to March 2020. And unfortunately, you can see here across all three age groups, 2 to 5, 6 to 11, and 12 to 19, that we've been seeing an increase in child obesity. We're using the growth chart data here for obesity to represent a body mass index from age, sex specific growth curves at or equal to 95th BMI percentile. So unfortunately, this data does show that in our adolescents, for example, 1 in 4, 1 in 5 kids already is struggling with obesity. In addition to that burden, we also know that there are differences, or what we call disparities, in child obesity prevalence. These are just a few of the factors where we have enough data to be able to look at to determine that there are differences. So for example, in our early data on 2 to 4-year-olds, the left-hand column here shows data we have by race and ethnicity. This shows, for example, among 2 to 4-year-old children as part of the WIC program, we see differences in the percentages of kids who have obesity. So for example, here, Hispanic and non-Hispanic Black children having higher rates than white and non-Hispanic Asian children. We look at geography, for example, children who are in cities have about 17.1%, and those in the country in non-metropolitan areas about 21.7, so higher by rural status. We see that same thing by severe obesity. And then over on the right-hand side, you can see a diagram showing by household income. So for example, again, among toddlers, seeing that among families with high amounts of poverty, it's almost double what we see in children from households with more wealth. And why do we care? And so as I've shared with you, the biology of obesity really shows that adipose cells as a metabolically active tissue are damaging the body and putting children at risk for both current disease and poor quality of life, as well as longer term issues. So for example, and we know in adults that 13 types of cancer are related causally to high adiposity. Child obesity tracks into adult obesity. Child obesity can increase bullying and stigma and lower self-reported quality of life. And the right-hand side shows more of the conditions across a variety of systems. So unfortunately, things like impaired glucose tolerance and early type 2 diabetes, joint problems, breathing problems, fatty liver disease. And so, and some of the data shows that childhood obesity is relatively inexpensive to prevent and treat compared to adult obesity. And therefore, preventing child obesity may avert future healthcare costs, as excess weight during childhood is a predictor of excess weight during adulthood. And so as I've tried to make the point, this is not about a cosmetic issue. This isn't how someone looks. This really is about disease risk. And this is an example of a paper from a few years back, but I wanted to just show it because many of us do support holistic health here. And this was around hypertension as an important modifiable risk factor for cardiovascular morbidity and mortality. This data comes from a new guideline that was put forth in 2017 from the American Academy of Pediatrics around some new hypertension cut points. In this example, if you look at the figure, we can see that this data among children in the United States from 2001 to 2016, using this new guideline, definitely shows that we've seen an increase in severity, an increase of risk through this prevalence of hypertension varying by weight status. So just quickly to summarize, this prevalence of hypertension varied by weight status ranging from 2% among children in the healthy weight zone to 14% among youth with severe obesity. So this is the type of data that we unfortunately have, but are showing, right, that this isn't a cosmetic issue. This really is a health risk issue. And during the last couple of years, CDC has been active in using electronic health record data as well as emergency discharge data to really look and see what was happening during the pandemic. And what we did show is that among youth with COVID-19, underlying medical conditions, including having high weight, increase the likelihood for hospitalization and severe COVID-19 illness. We saw in the data that the average rate of BMI change, what we call BMI increase, doubled during the pandemic. And this was especially true among kids who already had overweight or obesity and among children 6 to 11. This probably was partly due to the changes we had in schools being open, higher food insecurity, parks not being open. We saw an increase in incident diabetes in children less than 18 years of age who had COVID-19. This seemed to have increased during the pandemic, as well as an increase in emergency room visits for eating disorder conditions by youth. So just showing, right, that the pandemic has really impacted our children, and now more than ever, we really need to be understanding how we can support families and children. So as we think about that, we look to the evidence base and say, how can we ensure that the places that children spend their time are really having the most robust settings, policies, and environments to support children? And so this diagram is somewhat busy, but really shows that when we think about the whole school, whole child, whole community type model that's used by our sister division of school health, it helps us think about, in addition to schools, where else can we support children? And that's why I wanted to bring up here the child care, or what we call early care and education setting, as well as healthcare and community youth settings. So we really think it's important to improve access to quality education and quality healthcare that's not stigmatized and is equity focused. This includes healthy food options, supportive youth programming, and improved social determinants of health. We know that these programs can improve things like school readiness, social skills, and higher academic achievement, therefore helping the workforce of America. We also want kids to feel good, right? We want them to enjoy physical activity, have good relationships with their food, have a positive body image and self-esteem, and find healthy ways to reduce stress. This is really important as children are growing up in a time of high technology use and more social isolation. And all of this, right, can lower the risk for chronic disease, and so that folks feel better, both physically and mentally, and have improved quality of life. So I'm very excited to have shared this information with you, and hope that it fits in with other panelists that you're going to hear on ways that we can support children and families to have better health and to thrive in the United States. Thank you.
All right, so wonderful message from Captain Heidi Blank. We're going to move next to Carrie Duyema, who's also from CDC. Right before you get started, Carrie, we did want to note that our chat function is disabled. We just realized that. So if you'd like to put your name and your organization and whatever pediatric or family weight management program or intervention you're doing, you can go ahead and put that in the question and answer box. We would still love that information from you. Carrie, take it away. Thank you.
Thank you. Next slide. So I'm going to spend my 5 precious minutes thinking about the prevention of childhood obesity, and really how the early care and education setting can help our nation's children grow up healthy and strong. Next slide. Next slide. So really, what is the ECE, or early care and education setting? Well, it's the places where children 0 to 5 spend their time, such as pre-K, preschool, childcare centers, Head Start centers, and family childcare homes. We know that about 59%, or 12.5 million kids, receive care outside the home at least once a week. And center-based care is the most common, and kids spend a lot of time in this care, around 30 hours or more a week. We know that the setting directly influences what the kids eat and drink, and how active they are, and what opportunities they have. And we believe this is a child obesity prevention kind of aspect and setting, and really can set up kids for a foundation of healthy habits. Next slide. And also too, just thinking about early care and education, or ECE, as a great equalizer. So it's a key social determinant. It's a key, education is a key equity driver in our country. We know that the ECE setting impacts outcomes for children related to health and school readiness, and perhaps, as you see from the literature there, obesity prevention perhaps. So children who participated in Head Start had significantly healthier BMIs by kindergarten entry than comparison kids. And an extensive body of literature that demonstrates that participation in high quality ECE programs can improve long-term outcomes, such as substance abuse, lower adult BMI, less cardiovascular disease risk, and educational, social, and employment and income outcomes as well. We know that the return on investment for these programs is high, with a return on investment anywhere from $7 to $13. Next slide. I also wanted to point out and have people think about the things in their community, such as the Head Start programs. So a new study just released found 2 generational effects from participation in Head Start. So children who participated in Head Start had decreased teen parenting, decreased criminal engagement, increased educational attainment, increased wages. And these are outlined, these two generational effects are outlined in a recent paper in the Journal of Political Economy. Next slide. We also know that there are more children who need Head Start than there are slots available. So currently the Head Start program provides care or provides services for about 1 million children annually, but that supply does not always meet the demand. So you can see on this graph, it varies very much by state. So getting to know the Head Starts and the places in your community that are, keeping kids at their young age. You can see in Georgia, only about 31% of kids who are likely eligible because they are living in poverty are participating due to capacity issues. But other states such as Oregon, you can see have 80% of kids participating. And then if we think about early Head Start, kids 0 to 2, only about 10% of eligible kids are participating. Next slide. Really, I just wanted to focus a little and touch a little bit upon CDC's work. So we are currently working in 33 states and the District of Columbia, and also with many local jurisdictions to think about how we improve nutrition and physical activity and breastfeeding support in these early care and education settings, and how we aim for sustainable change. Next slide. One example of this is the nutrition and physical activity self-assessment. So ECE facilities in your jurisdiction may be able to participate in this evidence-based intervention that has been found to be cost-effective and also has strong strong evidence for impacting early childhood obesity risk. Currently, 22 states are using this intervention on an online platform, and many of these states are supported using CDC funds. And feel free to reach out if you'd like to get a list of the states that are participating. Next slide. So I really just wanted to kind of set the stage to think about prevention and treatment of childhood obesity, and the early care and education setting really being a key place where we can prevent childhood obesity, but also thinking about where the kids in your perhaps pediatric weight management programs are spending time, or if they have younger siblings, those kinds of things. ECEs provide high quality care for our kids. They're a social determinant. They help working families. And really CDC's work works to impact states, communities, facilities, and providers to improve nutrition, physical activity policies and practices so kids can get off to a healthy start. So I'm going to turn it over. Next slide. Thanks.
Thank you, Carrie. Moving right along to Carrie and Heidi's partners. We're going to be hearing next from Renee Porter and Allison Goodman, both from CDC as well. Go ahead, Allie. Thank you. You're on mute.
I think I've figured that out by now. Thank you so much. Good afternoon, everyone, and thank you so much for having us. Next slide, please. I'm a pediatrician and epidemiologist at CDC in the same group as everybody else you've heard so far today, and I'm here to speak to you about intensive family healthy weight programs. Next slide, please. So what is the evidence for these family healthy weight programs that you've been hearing about so far? So there's a U.S. Preventive Services Task Force recommendation that came out in 2010 originally and again reaffirmed in 2017. It's a grade B recommendation, which means there's a large strength of evidence that states that that clinicians should screen children ages 6+ using BMI and then offer or refer children with obesity to intensive family healthy weight programs. And they went on to state that these should include at least 26 hours of counseling over 2 to 12 months on nutrition and physical activity and behavior change, and really emphasize that this behavior modification was key. The evidence base for this was over 60 randomized controlled trials. So really, really strong evidence. So we know these can work. The question is, how do we get these to work in the real world? So how do we translate this from evidence to practice? Next slide, please. So what are the components of these programs? I already stated the nutrition and physical activity counseling that focus on behavior modification, but we know they need to be family-centered, right? Children don't have much control over their environment, and they exist in the context of people and all of these things that Heidi and Carrie have so eloquently discussed already. Skills training is also really key. We all know it's very hard to change behaviors. They need to address social determinants of health, and they need to be aware of bias, stigma, and shame, right? First, do no harm. We do not want to do any harm with these programs. We know that the higher the dose, quote unquote, the better the outcomes. So the USPSTF said over 26 hours over a 2 to 12 month period. We also think that booster dose or maintenance dose is probably important for having sustained effects. These programs can occur in clinical or community settings by a whole variety of provider types, which is really key. And there's lots of examples of programs working in group or individual sessions and by different types of modalities. In other words, virtual or in person, telehealth, etc. Next slide, please. But we have a lot of gaps in translation and uptake, and this is what CDC has been working on really hard for the last few years. We have a number of missing mechanisms for, again, getting this evidence into practice. I'm sure a lot of you are really aware of issues with payment and reimbursement and creating coverage gaps and limits. We've got low and inequitable availability of these services, and that's what we've been really pleased to work with NAC on. Lack of awareness of evidence-based obesity care, as well as a lack of packaged and accessible interventions. So in order to ensure that kids are receiving quality healthcare, we also have to make sure they're getting screened and referred. And for that, we need supply and demand, right? We've got to have a supply of sufficient reimbursable interventions available, and we need demand. So we need to know that providers are aware, confident in referring to these programs. Next slide, please. So CDC has a number of projects in this place, including CORD, our Childhood Obesity Research Demonstration Projects. This is a large research grant that's been going on for, we're in our going into our fourth year. It's from 2019 to 2024. That's all about how do we increase the availability and number of these evidence-based healthy weight programs that are packaged and ready for use in multiple settings. We have 5 recipients across this country that you can see there, the states that are available, and these are really aimed at packaging, adapting, testing, and implementing these effective programs. We already know they're effective. It's about how do we get them in the real world to children and families who are living with lower income. Next slides, please. You can see on the left who our awardees are, but just wanted to bring your attention to the mode and setting and interventionists, because I really want you all to be aware that there's a whole variety of different ways that this can happen, which is really nice because you can have that mix and match of what are the provider types that work for our health center or our community, right? Is it going to work better in group? Is it going to work better in person, virtual, clinic, community-based, rural, urban, and that's what we're really focused on, trying to get the field to a whole menu of options that are available in order to meet our patients and families where they're at. And now I'm going to turn this over, I believe, to Dr. Porter. Next slide, please.
Hi, can you hear me? Yes. One slide that actually accidentally got missed is the description of the program that NAC has been supporting, which is implementing MEND in health centers. And we'll go ahead and add that link to the chat just so you all are aware of it. As Ali just laid out, there are several effective healthy weight programs that are available. But as we have learned through CORD, flexibility is really key, including the need for multiple types of programs that can serve the needs of different clinics, communities, in person, or virtual. We've also learned that it's important for family healthy weight programs to be adaptable for specific populations. Next slide. With regards to adaptations, we sort of use the stoplight approach to really think about how adaptations can occur. And so we use the stoplight approach, which was actually developed and supported by NCI. You can see that adaptations in an intervention could be made regarding language or recipes, Other adaptations that might be, you may be able to add or modify to an intervention might be sort of thinking about additional outcome measures. And then really where we hold true to fidelity of the program is with red changes. We do not want to make changes to the core components, the components of the program that actually make the program work. Next slide, please. So I'll just kind of fly through this, but we sort of talk about adaptations to the intervention, and we view it really with equity. And so thinking about additional models or modalities like virtual modalities may ensure that additional people may be able to attend the program, ensuring language and culture, and additionally, as others have mentioned, really ensuring we're screening for social determinants of health, but as a point of intervention, so we really can provide those resources for the families to be able to better attend programs. Next slide. And in addition to intervention adaptations, we also think about systems adaptations. So in some cases, there may be data collection that needs to take place. And so perhaps supporting the intervention site to collect that data or to analyze the data. Also, implementation of multiple settings allows you to see sort of when one setting is succeeding and one setting may need additional support. Really kind of thinking about this from a very broad range is that we really do need multiple diverse, flexible interventions in order to meet the needs of all of the children who have excess unhealthy weight. Thank you.
Excellent. Thank you so much, Ali and Renee, for that. Now we're going to move into the program part of this. You're about to hear from Mona Sharifi with Bright Bodies, which is one of many examples we have to share about a specific program that you could adopt in your health center when it comes to that. So Mona, take it away. Tell us about your program. Thank you.
Hi, everyone. I'm Mona Sharifi. I'm a primary care pediatrician and health services researcher at Yale School of Medicine. I'm actually presenting on behalf of my team, in particular, Mary Savoy, who developed the Bright Bodies program, runs the Bright Bodies program, and has to date done all of the training to sort of disseminate the program to other sites. So I hope I do her justice in presenting this set of slides that she had prepared. Next slide, please. All right. So the program philosophy and eligibility for the Bright Bodies program really focuses on a non-diet healthy food choices approach. And, Mary Savoy, when she presents, always sort of emphasizes this non-diet approach is really a core function. We just heard from Renee about the importance of recognizing what are core functions, and this one in particular is a key one in Bright Bodies. Family oriented, where the parent or caregiver must participate alongside the child in group sessions, and generally eligibility has ranged from age 7 to 16, with children at or above the 85th percentile for age and sex being eligible to participate. Next slide. Okay, so the way that the program runs is in successive 12-week sessions that include physical activity sessions that are about 45 to 50 minutes in length, occurring twice per week, and that involves the children. Alongside that are, next slide, or next click, please. And you might want to just do a couple clicks so this whole slide loads in. Thank you. So nutrition education happens. Oh, I apologize. Let's go back one. So nutrition education sessions are once per week, and they involve the children and their parents together, while behavior modification and parent classes sort of happen concurrently. So the overall, the program meets twice per week with a mix of sort of nutrition, behavior modification sessions, and physical activity. Next slide. So getting into a bit more detail about these different components. The exercise component, the goal is really to instill a sense that exercise can be fun and is critical to achieving a healthy weight and maintaining it. Children exercise for about, like I said, 45 to 50 minutes twice per week while supervised by an exercise physiologist. The intensity targeted is about that kind of moderate to vigorous level of 65 to 80% of estimated max heart rate. Modifications are shown by exercise science students alongside the exercise physiologists. And children are encouraged to exercise 3 to 4 additional days and to decrease sedentary behaviors overall. Next slide. So the nutrition education component, the goal is to foster healthy eating habits for children with obesity as well as their families. These 40-minute classes happen once a week and are facilitated by a registered dietitian, grouped according to age. So kind of 7 to 10 is broken up, and 10 plus are kind of in different sessions. And they generally, these successive 12-week sessions go through beginner to intermediate to advanced levels. So this kind of maintained participation and sustained participation is really encouraged. The parent attends all nutrition topics with their child. And again, this non-diet, better food choices approach is really central. Next slide. So just comparing and contrasting this non-diet approach to a diet approach, really, again, focusing on lifestyle and behavior change rather than specifying specific foods for a given amount of time to lose weight. There's more of an emphasis on long-term changes to kind of perceptions around how we eat and what, how we make choices rather than short-term. Gradual, realistic changes and goals versus unrealistic, putting time and effort in rather than following pre-printed and specified directions, and really focusing more on education than information. Next slide. The behavior modification component seeks to help children replace negative behaviors that lead to overeating with positive, healthful behaviors while improving their overall self-image. I'll get into the trials around Bright Bodies that really demonstrated its effectiveness. I realize one bit of information we don't have is that some of the studies have shown improved self-perception scores using the Pierce-Harris scale associated with Bright Bodies. So this is really, in my opinion, a very important feature of the program. These sessions are 40 minutes in duration, facilitated by either the registered dietitian or social worker. Next slide. So the parent education component that's happening kind of alongside the behavior modification is meant to offer parents with ways to support their child with overweight and obesity and to provide a home environment conducive to healthy weight. Parents attend their own classes while children learn the behavior modification topics, as I mentioned. Next slide. So Ali and Renee covered this well already, but I'll just say that this 26 plus contact hours over 2 to 12 months, is one of the kind of main sources of evidence was actually the Bright Bodies study, among other trials that demonstrated kind of these higher intensity family-based multi-component approaches could really make a difference. And so we'll go to the next slide. We'll get into some of the details of what those trials found. So in 2007, led by Mary and other members of the team, the trial was conducted among 209 children who were randomized either to standard clinical care, which involved, every 6-month visits to an endocrinology obesity management clinic versus this higher intensity Bright Bodies program. And this was conducted amongst 8 to 16-year-olds, and they demonstrated a pretty impressive level of effectiveness. And we'll go to the next slide to sort of see those outcomes. So you can see that among the weight management group, which is the Bright Bodies program in the darker blue, over at 6, 12, and 24 months, there was an overall reduction in BMI Z-score, while the control group, which was the kind of more standard clinical control, actually increased their BMIs at 6 and 12 months. And there was a sustained difference, even though the intervention was really approximately 6 months long with a maintenance phase between 6 and 12 months. these changes appeared to be sustained through 24 months, a year after the intervention was completely ended, which was really encouraging. Beyond BMI, the study team also looked at HOMA-IR, a measure of insulin resistance, and showed similar sort of patterns of improved outcomes in the intervention versus the control group. Next slide. And this is just showing OGTT outcomes as well, that at baseline, the intervention and control groups were pretty similar, but at follow-up, the blue lines representing the intervention, both in measures of plasma glucose over the 2-hour period after a glucose tolerance test was administered. There was a significant difference. And then in plasma insulin, there was an even more kind of impressive difference between intervention and control. Next slide. So what we've had the pleasure of doing since we received some funding from the National Institute of Health to really explore the sustained effectiveness of the Bright Bodies program and the dissemination and implementation of the intervention since that trial was published in 2007. So we've collected data on all participants in the Bright Bodies program from 2008 to 2019 and look to assess, what happened since the trial. Did the program remain effective? And so we've been able to collect data from a large number of children who participated in the program. And we found that even though the program has had to adapt and evolve with the times, and various funding climates and staffing crunches have required adaptations to sustain the program, as well as to kind of keep families engaged outside of a trial setting, we've found that the program has overall remained effective. We also look to see if children with more severe obesity versus overweight had any difference in the degree of their improvement in BMI, and actually found that children with more severe obesity seem to have more significant, substantial improvements in BMI, which was also a very interesting and exciting finding. Next slide. So I'll just kind of leave it with this slide that we are in the process of conducting. We're actually just starting year 3 of a 5-year study looking, as I said, of the implementation of the Bright Bodies program. The program has kind of spread throughout the country as Mary Savoy has shared her curriculum and trained others in using the program at their sites. So we've reached out to those sites, conducted extensive surveys and interviews to learn more about the ways they've had to adapt the program, barriers to implementation, and we've used a lot of that information to optimize the program in a user-centered design. I'm honored to PI this study, and I'll just skip the next slide and kind of go to a couple slides later, if you don't mind advancing forward. Perfect. So yeah, this just shows our, we've done these interviews and surveys of the sites, and we're learning a ton. We'll go forward another slide. And so through this process, Mary, with the help of our team, has worked to optimize the curriculum, sort of updating it, making it much more user-centered and user-friendly. We're working with kind of experts in care for children from Spanish-speaking families to make sure that the curriculum works for them. And next slide, please. And we're kind of implementing the intervention in 3 new sites. Yes, as part of a prospective trial where we're going to implement this new optimized program with additional supports for implementation at 3 new sites representing populations disproportionately affected by obesity. And we're looking forward to kind of learning more and further supporting Mary in her efforts to spread the program. I'll stop there. Thanks so much.
Thank you so much, Mona. We could go on and on and on, but we want to make sure that we, oh, great, it's your last slide. We want to make sure we hear from Paul with the Healthy Weight Partnership. He's the director, and he'll be telling us about MEND, M-E-N-D. So you can turn your attention to him. Thanks so much.
Thanks, Sarah. Great to see everyone. I can see everyone's name, so I can see there's around 70 people on this call. So my name is Paul Sasha. I'm the Product and Science Director of MEND, which stands for Mind, Exercise, Nutrition, Do It. I've been working in this field for almost 25 years now, and MEND has been around for just over 20 years. So I'm going to do my best, next slide, to take you on a whistle-stop tour of MEND. However, I am aware that you'll all have access to this deck after the presentation. So apologies if I fly over some of them, but at least you'll have the decks to kind of refer back to. So what we aim to do with MEND is we aim to inspire children and families to lead and sustain fitter and healthier and happier lives. We don't focus on overweight and obesity itself. We focus on changing the behaviors that cause obesity and its associated sort of comorbidities. Next slide. We learned very early on that to deliver impact at scale, you need to be successful in all these crucial components. So you can think of this as a sort of the MEND Bermuda Triangle. And to survive the Bermuda Triangle, you need to really successfully navigate the three corners, which are clinical effectiveness, operational rigor. Programs need to work in the real world operationally and also need to be financially viable and sustainable. However, to have real impact, you really need to successfully navigate the center as well, which is all around the cultural competency of the program. Next slide. So we have a range of programs. All of them are US PSTF compliant. They targeted towards children living with overweight, obesity, or at risk of overweight and obesity. And our programs are sort of developed specifically for different ages and stages. So we have programs for 2 to 5-year-olds, 7 to 13, and then our newest program is Healthy Together, which is a more flexible, modular, lighter touch program, which is easy to deliver, and that's for children aged 6 to 13 and their parents or caregivers. Next slide. So as I said, MEND stands for Mind, Exercise, Nutrition, and Do It. And this slide just shows you some of the different aspects of the program, which you can refer back to for more detail. We also have a lot of videos on MEND on YouTube. If you want to just search MEND program, the US spelling, you'll see lots of examples of the program being delivered in the real world. We've had roughly just over 130,000 families through the program. Next slide. And so I'll just touch very quickly on some of our research. Next slide. So we've been evaluating the program since 2002. We've done a range of different evaluations from efficacy and effectiveness studies in 4 countries. And to date, there's been 35 peer-reviewed publications relating to MEND. And hopefully when you get this deck, that's actually a link which will take you directly to those publications, the references. And overall, the last time I checked a couple of months ago, we had 931 citations. So that means our research has been cited over 900 times in other research trials. And this really represents the most significant scientific impact across all community-based child weight management interventions. So we've learned a lot from all of this research, but what's even more important is what we've learned from our real-world implementation. Next slide. Just to sort of summarize what the research has shown in terms of health outcomes, this is just on one slide, just some of the main areas which we have evidence around. And obviously, with only 10 minutes, I don't have much time to go into the detail of some of this, but I'll come back to some of that in a second. If you go to the next slide. So we have our efficacy trials, which some of you may be aware of. We took part in CORD. We were part of the first wave of CORD trials. We have 4 randomized controlled trials in the 4 countries I mentioned, UK, Australia, US, and Canada. But this is some of our real world data. So these are families that have been through programs across the US in YMCAs, Parks and Recs, community health centers, schools, a whole range of different type of community organizations. And typically we see roughly around 90% of families who take part in the program are from African American or Hispanic origin. And we typically see underserved families as well. It would be our sort of majority demographic within the program. Next slide. This is just some of the before and after figures that we calculate based on some of the CDC metrics that we're asked to report on. And you can see improvements across physical activity, improvements in sedentary behaviors, reductions in sugar sweetened beverages, and improvements in diet, specifically fruit and vegetable intake. Next slide. We also, the thing that really speaks to me highly is the fact that we have an attendance rate just over 80% and a retention rate of almost 90% in our community-based real-world programs. We see improvements across psychosocial and psychological outcomes, body image, self-esteem, quality of life, and a whole range of other metrics. We also see significant improvements in cardiovascular fitness as measured by an objective step test. And overall, about 83% of participants either decrease or maintain their BMI Z-score after the Men 7 to 13 program. Next slide. Importantly, 90% of parents who attend our programs are living with overweight or obesity too. So it's very positive as a family-based program that we see roughly around just under 70% of parents reducing or maintaining their BMI as well. So we really sort of advocate a whole family approach, and that families and parents act as role models and the whole family gets healthier together. Next slide. So some of the practices and lessons learned, well, the things you really need to deliver pediatric weight management programs is you need the program, you need curriculum and resources, you need the venue, whether it's in person or virtual, you need your coaches, your leaders, your training framework, the session guides, and all the resources around training. You obviously need participants, children and parents or caregivers, you need the funding, and you need the partnerships. In many circumstances, organizations don't have all the facilities like the space required to actually deliver, for example, the physical activity component. Therefore, having partnerships with Parks and Recs or other organizations nearby can be quite helpful too. Next slide. So some of the example implementations that has led to the data I shared earlier has been the work we've done with a range of health centers. We worked on the Commit project in 5 states. We've worked with Denver Health Center, Lawndale Christian Health Center, but then also a wide range of other types of organizations, public health departments, community organizations I've mentioned. We also, the Y USA has the Healthy Weight in Your Child program, which is actually a licensed version of the MEN program based on the MEN program. And then we've worked across many school districts and universities too. Next slide. So some of the lessons that we've learned is that recognizing that everyone is different, you need to have flexible models for different circumstances, whether it be space limitations for program delivery or just monitoring and different monitoring and evaluation requirements. It's important to balance fidelity with the evidence, to the evidence base with adaptations, as Renee mentioned earlier. In terms of financial sustainability, you need some form of reimbursement, whether it's and that can be done in various ways, but particularly looking at different types of staffing models can be used in quite innovative ways to qualify reimbursement. For example, using RDs to take measurements, delivering in groups, and also really looking at different modes of delivery. So whether it's in person and virtual or hybrid, we have experience across all of those, and we've learned a lot of valuable lessons doing those. And the one thing we found that's really important, irrespective of the mode of delivery, is creating that group cohesion. It's much easier to do in person, but when it comes to virtual, getting that group cohesion, which is a major attraction for families, the social support, the fun element really comes through the group cohesion. And we have a lot of experience sort of making that work, whether it's virtual, hybrid, or in person. So what does this all mean in terms of lessons learned? Well, our biggest innovation really has come from working with health centers, in particular, the development of the Healthy Together program. Next slide. So I'll leave you with this slide to reflect on, but these are the lessons that we've learned by working with health centers, which have led to the Healthy Together program. And you can see how some of these real world lessons, real world experiences translated into actual learnings and resources and experience that health centers can basically pick up and run with, as opposed to reinventing the wheel. So with that, I will just leave you with the next slide, which is just where you can get more information on MEND at healthywaypartnership.org, and I'd be more than happy to answer any emails or respond to any interest after this meeting. So thank you very much for your time.
Thank you so much, Paul. And thank you to all of our panelists who shared today. We tried to give you some really good background about why this work is important, and then give you, just a couple of examples of some of those programs. So delighted. We want to thank our panelists again for that. A couple questions that came in, and we actually do have 4 minutes for questions. So again, if you go into the Q&A box and type in a question, we do have a little bit of time for our panelists to answer that, but I can go through just a few. Someone had asked about an example of how the farm to early childhood education has led to sustained benefits in local gardening. So our speaker, Carrie, was able to put a link into those answers to spearhead that. We also had gotten a question earlier about specific medication protocols when it comes to the new clinical practice guidelines and also just specific clinical guidelines when it comes to those medications. As we know, every body is different, and so certainly there may be room for some medications there, but we'll be answering that question separately on that. But I wonder if anyone has any other questions that they would like to put into the question and answer module. I know it's a little different not being able to use chat, but we can certainly see your questions and are happy to answer them. So I'll just give everybody a couple of minutes. And again, if you didn't have time to go into the question and answer module and put your name and maybe a program or an intervention or initiative that you've done at your at where you work, there's certainly time for that as well. So let's see. It looks like I think we just had someone check in. Wonderful. We've had 70 attendees on this, so we're really grateful to you for that. Again, just as a quick wrap up. Oh, good. We just got a question. This is an interesting one. So we'll let our panelists fight over this one. How are complementary alternatives like chiropractic used? Or maybe another example. Would any of our panelists like to take that question? Or anybody have experience with that? Don't answer all at once. Or acupuncture, or any alternative. Any of that? Would any of our panelists like to take that? Oh no, thank you.
I'll take a stab. I will confess that I don't have a lot of information to share on this issue. I know that the evidence around acupuncture and some kind of more gentle chiropractic treatments can be helpful in managing some forms of pain and kind of joint pains, or we know are kind of a co-occurring condition with obesity. So that might be the place that I could see it, but I'm by no means an expert on that area, and would be interested to know more if anyone out there has more information. I did also, I wanted during my presentation to do a little plug for the upcoming, the American Academy of Pediatrics is about to release updated guidelines for the basically to be used by primary care pediatricians, but also weight management specialists around obesity management for children and adolescents, and that's coming out in time for the AAP conference in mid-October. So folks want to keep an eye out for those guidelines coming out, as well as lots of educational materials around that. May address the topic of GLP-1 agonists that someone had raised there.
Excellent. Thank you, Mona. We did actually get an answer from Maggie Vroman. She's one of our commits, what we call legacy sites, someone who's been working along with NAC and the CDC in this work. And so she suggested a dental guest speaker and the yoga instructor. So certainly that was a great question, and we could certainly take that offline. It is time. We have run through. Thank you again for your participation. I just wanted to remind everybody that because you participated today, we'll be sending up some follow-up email with some more resources, as well as the slide deck here. What flickered quickly on the screen was our Care Digest, Care Teams Digest. That is a newsletter that our Clinical Affairs Division actually spearheads to talk a little bit more about the different initiatives and just awesome work that health centers are doing in a variety of different spaces. I think the newsletter comes out bi-monthly. It's right there. Perfect. So if you want to take your phone and sign up for that, or you can contact anyone of our team of NAC to get access to that. Thank you again to our panelists today. Feel free to reach out to any of us for more information. We'd love to chat with you about different programs going on, or just answer any questions that you have. We will let you go into the rest of your Tuesday. Thank you so much. Be well.